So thanks for the opportunity to be a part of this. The Care Transitions Innovation is a hospital-to-home transitional care program that Devin Consagra and I lead, and Stephanie Pena is our transitional care nurse. Several others here are also very involved. It's a transitional care program from hospital to home for uninsured and low-income publicly insured patients. And just a very brief history is that the work really came out of a recognized need that, in particular for this patient population, care in the Portland metro area is very fragmented, and that patients were experiencing bad outcomes and that the system wasn't supported to provide quality care. And so over the course of several years, we had an ongoing needs assessment and developed a program that really has four main components. And the components include, early on, identification of patients. This isn't one of the key components, but we identify patients and are actually studying this in a randomized controlled trial right now, and we're still in that ongoing study phase. However, patients are identified based on being a part of a medicine or cardiology team, and then their insurance status and where they live geographically. And the components of the intervention include a transitional care nurse. Stephanie meets our patients in the hospital and early on does a needs assessment, really trying to understand, and as many of us have said today, the importance of transitional care starting on early in admission and not on the day of discharge. So trying to identify what our patients' transitional care needs going to be in the hospital, and working with patients and our multidisciplinary team, developing helping expand patients' understanding of the red flags and warning signs that they need to be aware of so that they can better self-manage their care after hospitalization. Stephanie develops a personal health record with patients. That's a patient-centered document that travels with them from the hospital to their post-hospital care. And she does home visits with patients, with our highest risk patients, within 3 days of their discharge, and then we link patients with primary care. The other four components, so we have component one is a transitional care nurse intervention. We've linked closely with our pharmacy team, and in fact, from our needs assessment, learned that uninsured folks frequently are given loads of prescriptions, they can't afford them and don't take them and self-ration. So we've worked with our pharmacy team to help guide prescribing so that they match Medicare and Medicaid formularies. And for the uninsured, we provide 30 days of meds through a formulary that we developed as part of our program. The third piece of the intervention is medical home linkages. So for uninsured patients, they're really not able to access primary care in the community given the restrictions of a safety net that's already tight. So OHSU's partnered with 3 clinics and is actually paying for primary care for folks. And then the last piece that I think may be very widely applicable to all patient populations is that we really have an explicit effort to integrate these fragmented and siloed aspects of the care system. So we have monthly meetings where various representatives from all the different arms of our program come together, and we go through specific patient cases, and we really actively engage in ongoing continuous quality improvement. So we are an adaptive model. There's very clear, or hopefully clear and open lines of communication, and that's something that we've been continuing to work on as we evolve. Might have been too long an explanation.
No. Very good. Thank you. Rebecca.
Thanks for inviting me. My name's Rebecca, and I'm here representing some of the transitional care efforts that Care Oregon has been involved in. And I have a team of clinicians at the back table that actually know more about a lot of what we do internally. I'm going to give the big picture, but if you have any questions about our health plan activities, you should talk to Kylie, Cheryl, or Margaret, if you want to raise your hands. They're the real experts in the room. So there are basically 3, and maybe I'll add a 4th given some of the comments from the last panel, activities that Care Oregon has been involved in over the past several years. About 3 years ago, we actually did some, right around the time when a lot of the writing of Dr. Eric Coleman was coming out, we did some work to modify the care transitions model that Dr. Coleman has studied and written about to be used telephonically, because we have a bunch of case managers at the health plan who do most of their work telephonically, and we thought, well, you know, we don't really have the capacity to do the full model where someone like Stephanie is actually meeting patients in the hospital and maybe even making home visits, but we know we can do a lot of work on the phone, and we had shown some pretty good outcomes in terms of reducing hospitalization rates just through a pretty robust telephonic model. Although I would make the caveat that I think face-to-face interaction is really critical in this. But given the resources we had and the program we had, we designed a telephonic transitional care support model, and basically a team at Care Oregon driven by nurses, behavioral health specialists, and healthcare coordinators actually provides telephonic assistance to members after they've been discharged from the hospital. Often that contact occurs when they're still in the hospital through concurrent review nurse activity in the hospital. So we have a lot of links between different staff that work for Care Oregon. So we're really trying to move the time that we start assisting members to as close as possible, even during the hospitalization if we can. And then basically members are assisted for about 30 days after their discharge, and we do things like making sure that they understand their red flag symptoms, that we do as much as we can in terms of medication reconciliation using our clinical pharmacists at the plan and looking at med profiles based on claims. We request hospital discharge summaries, and we try and get those to PCPs and specialists if they haven't received them through Care Everywhere or other modalities. So it's a lot of teaching and support. We work on making sure any DME that has been ordered has actually been delivered in a timely and effective manner. We work through pharmacy barriers, so if there was a drug that was prescribed as part of the discharge process that ended up not being on our formulary, that can often create barriers for our members, and so we end up with patients who actually aren't taking the medications that are critical for them to remain stable when they get home. So lots of more specific interventions that I don't have time to talk about all of them, but that's probably our flagship transitional care program. The next two I'm going to just briefly mention are things that are actually just in the design phase, and I think it's great that I'm actually sitting next to two of the people that I collaborate with most often on these projects. We're actually developing what we're calling a hotspot program based on the Atul Gawande article that I think was referenced earlier. And so we're building clinical outreach teams that will actually go and do much more of a face-to-face home interventions with high-risk Care Oregon members, and most of them are referred to us by providers. So we're really looking at that. We're really basing our target population on what clinicians believe to be their most risky patients. And so, just as an example, Jane Mitchell has really worked at identifying Care Oregon members who are admitted for a primary diagnosis of congestive heart failure, and recognizing those patients that are either repeating in terms of admissions or just clearly have need for additional support, social support, educational support. A lot of them have some cognitive delays, really need help putting together the system of care at home to prevent them from being readmitted. So we're sending out outreach workers. We're hiring right now or recruiting for nurses and behavioral health specialists to really provide a deep, much more in-depth touch for these members. And so we're really excited about this, but again, I don't have any results to share other than some great anecdotes. And then the third initiative is something that we're really trying to do across the community, and that is to facilitate conversations with hospitals and primary care clinics to develop a standard transitional care process map. And the reason why we started thinking this was so critical was that we spend a lot of time working with our primary care providers and the network of primary care providers. And no matter how excellent a hospital's discharge planning process and transitional care intervention might be, from a primary care perspective, it's completely unrealistic for them to be able to engage and participate in 6 different versions of that transitional care process. So until we have a community-wide standard that allows primary care and to some degree specialty providers to really sort of understand on a patient-by-patient basis what they need to do to improve the likelihood of that patient not being readmitted, we're not going to get very far. And so we're really trying to sort of get everyone at the table and co-develop a process that will hopefully work with minor tweaks for each institution. There was a question, and I think it might have been Tony, I can't remember where it came from, to Devin about getting the patient perspective in terms of risk prediction. And I just wanted to share that there is an assessment that a number of us have created out of a need that was communicated by primary care providers. It's an assessment that providers are testing across the country in a number of settings. It's an 8-question assessment that asks patients to identify it prompts patients to talk about some of the root causes of risk that they may be experiencing. And one of the questions actually asks patients to tell the provider or whoever's administering the assessment, do you believe that you're at risk for a hospitalization in the next 6 months or an ED visit? And then, it further asks questions about why. And the interesting thing that's happening is that providers that are using, it's called the HARMS 8, and I'd be happy to send it to anyone who's interested in looking at it, but providers are finding that with these questions that really are looking at sort of the socio-behavioral risk factors that patients have, they're finding things out about their patients they had absolutely no idea. And these are physicians that are really, they interact with their patients in a deep way, but by using a standardized questionnaire format and really looking for the patient perspective, they're finding out things that you'll never get if you use a claims-based predictive model that are really important in terms of modifying risk. So, all right, I took up way more time than I needed to.
That's fine. I got this.
Okay.
Thank you, Rebecca. That's very good comments. Jen?
Thank you.